Hello, everyone. My name is Crystal McCauley, and I am very blessed to be a member of the 2020 Mom team. I have the pleasure of introducing to you our final panel of the day, which is a replication, actually, of a panel last year that was voted most popular. So thank you all for your feedback, and I'm sure you're going to enjoy this very, very much. I'd like to introduce to you our moderator. Her name is Jane Van Dis, and she's a board-certified OBGYN and medical director at the Maven Clinic, the nation's largest telehealth platform for women and families. She delivers babies at Verdugo Hills Hospital in La Cañada, and she's also a founder of Time's Up Healthcare. Jane?
Thank you. I'm actually going to introduce the moderator. I'm just like the introducer of the introducer. So I'm introducing Blair Dudley, and she works with one of my favorite groups, which is the Pacific Business Group on Health. And she leads the Transform Maternity Care program there, which focuses on care design, payment reform, and employer engagement initiatives to promote high-value maternity care. Awesome. She has nearly 10 years of experience in the healthcare industry, focusing on quality improvement, population health, and value-based care. Please lend a warm welcome to Blair Dudley.
Well, I feel very excited. I feel like I got an upgrade just now. I was like, ooh, I'm a doctor. This is great. So I'm Blair Dudley, and thank you for the lovely introduction. I lead PBGH's Transform Maternity Care program, and I want to thank the participant who was asking what can employers do to drive improvements in healthcare. This is your session. We are hopefully going to answer some of your questions and really have a robust discussion about what can both employers and payers do to further improvements in maternal health and in maternal mental health. So at PBGH, our program has been focused on a couple different program development solutions to succeed in a high-value maternity care vision. And that looks like promoting the use of nurse midwives, trying to reduce unnecessary interventions, not only looking at the cost to the whole system, but also trying to reduce unnecessary trauma to mom and baby and family. And then, of course, promoting, nothing says high-value care, like looking at not just the medical, but the mental health side of things. So we're actively and currently engaging in strategies on that front, including not only quality improvement, but specifically quality measurement. And we're actually working on a project right now in San Diego, so it's even better. I'm not sure who oh, great, thank you, was shouting out this work. So we're working on a project to develop a prospective maternity bundle, and as part of that work, we're going to be measuring the newer NCQA measures of perinatal depression screening and follow-up, so both the prenatal and the postpartum. So we're looking forward to sharing, hopefully next year, what comes out of that work. So we're going live with our bundle April 1st of this year, which sounds very quick in my mind. But in any case, let's, as they say, get this party started. So it's almost 4. And so just to get everybody excited, we don't have a lot of maybe dwindling energy in the room, so we'll use the mantra of Maternal Mental Health Forum. So I'm going to say, we can. You say, do more. Ready? We can. Do more. All right, that was okay, but we can. Do more. Okay. I was not a cheerleader, as you can tell. Okay, so I want to welcome our esteemed panelists up here. What we'll be covering today, like I said, is how employers can be powerful drivers of change through network and benefit design, consumer education, and working directly with payers and providers, and how insurers, both commercial and in the Medicaid space, can promote maternal mental health. So let me do a quick round of introductions so that we can dive into the meat of this work. So we are joined today by Rick Hecht, who has over 25 years of strategic leadership experience in the healthcare industry. This includes experience in hospital and practitioner settings, managed care organizations, health plans, insurance providers, and integrated delivery systems. He's been a behavioral health licensed California clinician for over 25 years and is the director of behavioral health at Willis Towers Watson, providing consultation and subject matter expertise to employers and organizations. So thank you, Rick. Second, we have Carole Mendoza, who leads the Global Health and Wellness Benefits team at IBM in the Human Resources Group. And Carole is a certified employee benefits specialist and earned her MBA right near here from the UCLA Anderson School of Management. Thank you, Carole. Next, we are joined by Jennifer Moore, who is an internationally recognized leader in the Medicaid and maternal child health space. 20 plus years of experience. Her work is really at the intersection of practice, research, and policy, and we're thrilled to be joined by her today. And then we have Pooja Mittal, who is a family physician and works as a medical director at HealthNet with a particular focus on furthering equitable care through a population health model at HealthNet. Thank you, Pooja. And last but not least, we are also joined by Stuart Lustig, who I will skip your introduction, not only because we've already gotten a lovely introduction of you today, so thank you very much.
I'd like to say of all the many introductions I've enjoyed over the years, yours is certainly the most recent.
Well, thank you. I'll take it. Thank you very much. So we're going to start with a little bit of a round robin, and now that we know a little bit about who all of you are, we'd like to hear a little bit about your organization and your role there, and give us a kind of brief overview of your focus on maternal mental health and behavioral health in general. So we can just start down the row. Rick, do you want to start us off?
I'm Rick Hecht. I am the director for behavioral health for Willis Towers Watson, which is a very large advisory, brokery, and solution consulting firm. They are the third largest brokerage firm in the world. They're in 140 countries, been around since 1828, back when I got my license. And it's really organized around 4 businesses. And the business that I work for is human capital and benefits. And within that division, there is retirement consulting, technology administration consulting, and then talent rewards, and then what I do around healthcare and benefits. And so my job is to support a whole bunch of consultants around the country who go out and talk to customers around their benefit design and different ways to keep their folks healthy. And I'm the behavioral health subject matter expert. So I've been there all of 8 months. So just trying to figure out what they do and what I do.
Hi, everyone. Thank you for hanging in there, for staying here for the last panel. As was introduced, I'm Jennifer Moore. I'm the founding executive director of the Institute for Medicaid Innovation. The Institute is a 501c3 nonprofit research and policy organization. We work with a lot of different Medicaid stakeholders that oftentimes do not work together, but bring them together around salient issues that they all agree are important. Maternal depression and anxiety is one of them. And one of the projects that we're leading right now is funded through the Robert Wood Johnson Foundation. And we're looking to transform health system and payment reform. And what we're doing is we're bringing together teams as part of a learning collaborative. And the teams consist of state Medicaid agencies, Medicaid managed care organizations, and provider groups, and members who are enrolled in Medicaid. And through this process, we have identified 7 states. And the 7 states, the teams that I just shared with, have identified areas that have disparities or issues of equity that are at the top of their mind. 2 states identified maternal depression and anxiety amongst all the issues in Medicaid. And so we're going to be working with them over the next 3 years to identify how they address, like many people brought up earlier, the issues of payment. the issues of how do you do this within Medicaid? How do you bring together these different stakeholders to advance this issue? And as if this is of interest to you, you can definitely check us out on our website. We've got more information. We're funded through the California Healthcare Foundation to do a comprehensive report, doing a national scan to look at what's going on in the space of maternal depression and anxiety. We have an annual survey where we collect information from all of the Medicaid health plans to get a sense of what's going on in the industry. And that's just a snapshot of some of the work that we're doing in this space.
Hi, thank you. I'm Carole Mendoza. I am the employer on the panel. I work for IBM. Does anyone not know who IBM is? Probably, okay. I am responsible for health benefit strategy globally for our 400,000 employees. And I'm personally passionate about this topic, and I think we can do more to address maternal mental health for the half of the U.S. population that is covered by employers.
I'm Pooja Mittal. I'm a medical director at HealthNet, and I actually work in the PPO line of business. But about half of my work is looking at population health overall and thinking about how we can provide the right care for the right person at the right time. And in that area, and also building health equity into that, is where we've actually really been able to start taking a look at maternal mental health and how that fits into the whole family and the whole structure of healthcare, where otherwise healthcare is quite siloed and we end up looking at really the individual and not sort of the long range effects that we know mothers have on the rest of society.
As a child psychiatrist, I'm particularly interested in the well-being of children. And one of the things that we've learned from William Beardsley's work almost 2 decades ago in preventive interventions is that the best way to prevent depression in kids is to treat it in mothers. So I'm particularly interested in this population as well. And I can tell you in my role at Cigna, which is to interface with many of our clients who are large and small employers, that everybody is aligned on this. We want people to get care. You all want patients to get care, and none of our employers who are our clients want people knocking on their doors in HR saying that they can't get in to get the treatment that they need. So I'm here to really learn from all of you and get some takeaways that I can bring back to our provider relations teams and strategies to share with our clients potentially as well. So looking forward in particular to this panel.
Well, thank you, everyone, very much. So I want to start us off and get this question back to you, Jennifer. Actually, so if we can hand a mic back down to you. So you mentioned your, I believe, 2018 report to give really a comprehensive overview of the impact of maternal behavioral health disorders. And I would love for you to share with us, even just briefly, how those maternal mental health disorders can affect not only birth outcomes, but also behavior patterns in the child.
Yeah. So is this on? Hello? Oh, good. So thank you. Again, I have to thank Stephanie for believing in the work and helping to support through the California Healthcare Foundation, looking at this nationally, but also honing in on California. I cannot emphasize enough that California is an incredible innovator in terms of maternal health, full stop. And to have such strong support from foundations in this area really contributes to that success. So thank you, Stephanie, and others in the room who may be representing that area. So this morning, a lot of information, a lot of data was thrown at you about the impact on mom and baby, but some of the key pieces that we found as we were looking at the data and the research that I didn't necessarily hear brought up, but was underlying the presentations, is the impact on preterm birth and low birth weight. These are big issues in the Medicaid space, which all of you are very familiar with. We also know that maternal depression and anxiety has an increased risk of child abuse and neglect, developmental, behavioral, physical conditions and issues that arise. And we also know, especially in the Medicaid population, that there's an increased risk that that child will be put into foster care. And foster care is a really important topic for us to consider as we think about this issue. But I also wrote down a couple of stats that I just want to throw out there because I love numbers. I'm a researcher. But 19% of new mothers experience depression during the first 3 months of postpartum. And then of low-income women, I'm on this panel, I'm going to talk about Medicaid the whole time, so get used to it. Greater than a third of women in Medicaid do not receive treatment. That is not acceptable.
Thank you very much, Jennifer. That's really helpful thank you for starting us off and looking at this global view of mom and the whole family unit. So now I want to really turn first to our employer voices. And Carole, I'll start with you to say, is maternal mental health a priority for employers?
Yeah, it's a good question. I don't think that maternal mental health is a priority for employers, but I think maternity care is a priority and mental health care is becoming a much bigger priority. So there is an opportunity at that intersection to get employers involved in this issue.
Thank you. Well, and Rick, I wonder if you can weigh in as well, just kind of telling us what trends you're seeing.
I agree. I think just mental health in general has become a real priority for employers. We've seen a 30% increase in suicide in the last 20 years. 47,000 people a year kill themselves, 67,000 overdoses last year. So they're sitting up and taking notice. It's really mental health for the first time in my 30 years in the industry has really become part of the national conversation and really part of the sort of global zeitgeist in general. This isn't just an issue that we're dealing with here in the States. As far as maternal mental health, I haven't really talked to customers about that. I don't know enough about it. I know that the work that Joy and this organization and the people in this room are doing is incredible. I have been blown away and humbled by just the brilliance and the passion that I've been hearing all day. So I appreciate that, and I've learned a lot from you guys.
Thank you both very much. So I want to ask the same question of our health plan participants. And Stuart, perhaps we can start with you to say, how is this a priority amongst health plans? And then Pooja will come to you next.
Yeah, well, I think if you were to ask anyone at our organization, what's the best job that we have in all of Cigna? We've got 75,000 people or so working for us at this point. The people who would probably stand up first to say, I've got the best job, would be the frontline clinical case managers who are engaged in case management and coaching programs. And we have in behavioral 900 people in operations. Many of those are case managers and people who are on the phone directly with moms. Moms to be. We have a healthy moms, healthy pregnancies, healthy babies program where moms can call in and we call out to them. They can get anything from information about what foods to eat, what foods to avoid, how to find a good birthing class, where to find out about breastfeeding, delivery questions, all of that. And importantly for this group, they do screening as well for depression, and they know when to refer to our other group of case managers who are sitting in our behavioral organization. So I think our biggest priority is reaching out to people who are in need and following up with them after pregnancy as well.
Thank you.
So at HealthNet, we have a similar program that we call Start Smart for Baby that's really focused on pregnant women and reaching out to pregnant women. But I would agree with you, actually, that I don't think that maternal mental health has necessarily been the top priority. I think maternity care is really important and mental health care is really important. And those things are still quite siloed. And as we start to move towards more thinking about populations in general and healthy people and less healthy people and what do they need, insurance companies are starting to notice, right, that the woman's health affects the family's health, that she's often the decision maker about what health plan they're going to choose, right? She's often the one making that decision. And so we have to make sure that we're paying attention to her health if we want her to be happy and if we want her to stay with our plan, stay engaged in care, and bring her family in for care.
Thank you both. Well, and to build on some of the things that you've just described about these programs that are happening within both of your organizations of Cigna and HealthNet, I want to ask both Carole and Rick. So, Carole, how much do you know right off the bat? The resources that are available at your plans. Is that with your role being so broad and maybe healthcare is a piece and maternity care is a smaller piece beyond that. How do you find it easy to know the programs available, or what are some of the challenges you see there?
I think the typical employee has no idea the vast array of programs that are available, and finding the right program at the right time is a real challenge for employees too. And if you think about, if I try to communicate with you about all of the wonderful things that we have available, if it's one more thing in your email box, if it doesn't resonate at that moment, you're going to delete it. So I think we have an opportunity as employers to find different ways to outreach to moms who are in need. And as an example, something that we did when I was with a prior employer was to send out baby kits to moms who were pregnant, who self-identified and said that they wanted them. We didn't want it to be creepy, but included information about postpartum depression, maternal mental health, just to raise awareness so that they could think about if they weren't feeling at their best and thought that something might be wrong, they could then outreach to the EAP.
I love what Carole said. It's sort of the broken record that I go out with, is that you have to keep this in front of people all the time. A lot of organizations during Mental Health Month will send out a flyer about their EAP, and it's sort of like if you're in the market for a car, every commercial that you see on TV is a car commercial, but the other 11 months a year, you don't notice them. They're still there. It's the same, keeping things in front of people. The health plans that I meet with, almost all of them address maternal mental health care in their condition management programs. They actually screen for depression across most condition management programs. So it's encouraging. We go out and we do chart audits, and we see the notes, and that people are really following through. And a couple of the health plans have really customized programs where they do outreach and screening, even postpartum. So it's encouraging to see that it's happening out there.
Thank you both. Well, and now I want to come back to Stuart and Pooja, because you gave us a kind of a general overview of some of the things the programs that are happening at your organizations. And now I wonder if you can touch on some of these innovative solutions that are kind of newer and have developed more recently. What are some of the takeaways that you want us to know about these new programs or new policies?
So one of the new programs that we're launching specifically to address this issue is WellFrame, which is a digital platform that is an app-based platform for your phone that's actually patient-facing, that allows the patient to interact with the health plan directly. And so one of the first programs that we're launching is the maternity care program. So it offers the patient direct contact with the case manager, who will outreach and evaluate their risk for an array of different things during pregnancy, but also postpartum depression or maternal depression. And it'll provide an entire educational suite about all kinds of things that are pregnancy related. And it also will offer her an opportunity to sort of have a back and forth with somebody directly at the plan about whatever she needs. So our case managers are nurses, and so if it's something that's medical that needs a clinician to respond, the nurse will respond. And we also have program coordinators who are part of that conversation. So if she needs, for example, some support getting connected with a therapist in her area, that person can then step in and help. And she can access all of that through her phone, because I think one thing that's maybe a downside of many of the case management programs that health plans use is that they're very telephonic based and not necessarily that convenient for the member, right? It's like I was in a case management program for my pregnancy that was high risk, and I remember I would get a call at like 2 p.m. Can you talk to me now about your high risk pregnancy in the middle of your workday? And it's not always that easy, and I think it's much easier to allow patients to outreach to us when they have access.
You know, in addition to the Healthy Pregnancies, Healthy Babies program that I mentioned, we also have a high-risk pregnancy case management program as well. We use the PHQ-9 to screen for depression in that program. But following up on the access issue that you raised, the other area where we've been quite focused in the last few years is virtual behavioral health, telehealth as we think about it. And although it feels very new and exciting to all of us, you know, the Australians were way ahead of us 20 years ago. They had figured out they've got this massive continent, and the only way they're going to serve you know, the 20 million people spread out over this massive continent, or if they could get people to connect virtually. And so we are catching up at this point. Being a researcher at heart, I am particularly interested in a project that we are now starting, which is to look at actually who's using this. Is it, for example, those lonely young people, or is it the isolated older people that we were talking about before? Is it the new mothers, for example, or is it folks who are pregnant and may have difficulty with mobility or precious little time, who are taking advantage of the extra time in the day saved by not having to commute to see your clinician. And also rural versus urban, who's really using these things. So I'll have more on that next year when I see you all again, hopefully, but we're tracking that now. So that's also where we're very hopeful that that's going to help a lot of people to get care more easily.
Thank you. So, so now I want to ask a little bit more, Carolyn, I'll put you on the spot again, because I want to know, what would you and you know, some of your peers and other engaged employers like to see change in payers to address the growing maternal mental health challenges?
I think we're actually very aligned, and it's reimbursement. I think some progressive employers have started working with EAPs that are reimbursing at higher rates to draw more people into the network. So people who won't connect with anybody else, won't contract with anyone else, will work with these EAPs. And it's not only about having more people in the network, but also doing more outreach. So I'll use actually my own personal example. I called the EAP number when I was struggling, and I got a list of 3 providers that I could call. Nobody took my call, nobody returned my call, and so then I had to go back for another list. That's incredibly frustrating for women who are struggling with this. So some of these EAPs are helping to make those appointments for moms, and I know that Cigna's doing some work around this as well, so that they're not having to deal with just one more bit of friction or one more point of frustration. So I think reimbursement, and we're willing to pay more, especially if you tell us that it's needed, and we want to make it a better experience when moms do actually reach out.
Can I follow up on that? And I'm glad you said what you said, because one thing people may not realize about companies like Cigna, for example, is that most of our employers are large employers who are not paying us to assume risk. If you're IBM, you guys are huge, probably bigger than we are, right? You can afford to underwrite the risk for your health plan, but you're not in the business of managing that and being clinicians. And so it's actually IBM's money on the line, quite honestly. And so for you to say, and this is helpful for us to know, yes, we want to make this available. Our obligation to our clients is to provide an affordable network, a robust network, and we check with the people in our network every year to make sure that they are still accepting patients, or at least that they haven't retired, or even worse, died, because that happens. So, but we want to, we need to offer a value-based network, but also, we don't want any noise around people not being able to get in. So when you guys say, make it happen, that's helpful to us to know.
To let you off the hook a little bit too, I will say that employers for a long time have been really focused on how do we drive down reimbursement rates because we don't want to pay any more for health care. It's becoming too expensive. But the comment that was made on an earlier panel about cardiologists, and we're not talking about cardiologist reimbursement rates. We just want to make sure that there are enough cardiologists in network. We should feel the same way about mental health professionals.
So I agree with all of that, and as Dr. Phillips eloquently put it earlier, they've been paying crap for many years. What I got 28 years ago in practice was not a whole lot different than what they were paying 5 years ago. But money isn't going to save it by itself. So right now we have such a shortage of providers across the country because they could go do other things like be a Walmart greeter or something and make more money than we were getting after paying office and billing and insurance and all of that. Today, 110 million Americans, about a third of the population, live in an area that's designated as having a provider shortage. Psychiatrists, 50% of the counties in America don't have a psychiatrist in them, 50%. Stuart happens to be a real unicorn in that he's a child psychiatrist. You can't find them anymore. People have gotten away from that, and it's been because of the money, but bringing money back in or paying higher rates. So there are some organizations we talked a little bit about. There's one that sort of reinvented EAP, and they're paying $150 a session instead of 60 or 70 bucks. And what that's doing, though, is actually pulling people off the Cigna panels and the United panels, and it's actually making the problem a little bit worse. So we've got to find some other ways to treat people, and we've also got to get people back into the profession.
Hear, hear. So thank you. I want to ask a question because we've been talking a little bit about how network design makes a big difference and these kind of logistical barriers and providers in network and things like that. And I want to merge the kind of commercial side of things with the public and Medicaid side of things and ask the question. We'll start commercial. So Carole and Rick, we'll start with you and then head to you, Jennifer. But I want to ask the question of how do you as a purchaser think about not just the kind of system level considerations, but how do you get that individual motivated to get themselves to care, particularly in this kind of space at a hard, vulnerable time? And how do you see benefit design as potentially a lever?
I think awareness of the resources that are available is incredibly important, and then breaking down as many barriers as possible to care. And one thing that I think some employers are starting to do too is to increase the number of visits that are available under an EAP. Many large employers have gone to high deductible health plans. So even when you can find someone in network, you're still having to pay 100% of the cost until you've met your deductible. So the more that we can provide outside of the health plan in an EAP, the more access there will be to, hopefully quality care at no cost.
Yeah, I agree. There are really, so 60% of people that experience a mental health disorder in a given year don't seek care at all. And there are really 4 levers that we have to pull. And one of them, the first one, is awareness. People, one, don't understand that they have a mental health condition. So there are some vendors that we've been working with out in employers that go out and really drive home. If you guys want to Google something cool, it's called Angst, the movie. And this is a woman who was a film producer that started making some mental health films. And so we've used that with some customers to really say, hey, this is what anxiety looks like. Awareness is one. Breaking down stigma. Stigma still exists today. So going out and developing anti-stigma campaigns and communication. And again, it's got to be all year long. The third one is what we're talking about with access, just providers are looking at innovators and disruptors that are doing it a little bit differently, so people get care. And the last one that Carole just mentioned too is cost. So if you have a high deductible health plan and you're feeling depressed and you want to go get care, but it comes down to you paying for the therapist or putting food on the table, your mental health is going to take a back seat. So we're seeing a lot of employers, working with a lot of employers as well, to sort of reimagine their EAP, to find new ways to brand it, to promote it. This is a no-cost service to increase the visits. So if you can pull those 4 levers, people will start getting the care that they need.
Thank you. And so, Jennifer, now if you could give us a little bit of insight. I know you were mentioning earlier that Medicaid moms in the 4th trimester accessing care, there's not as much utilization as you'd like to see. So, thinking about it from that standpoint, what are how could you? What would you like to say to Medicaid fee-for-service and managed care plans alike, or separate, however you want to describe it, to encourage more utilization, particularly in this postpartum period?
Yeah, I think we need to recognize what the life of someone who is enrolled in Medicaid looks like, and it's very different than someone who has employer-sponsored health insurance coverage. So a lot of the comments that were made resonated with me, who has employer-sponsored insurance. But when I think of the patients I work with at the clinic, I work still at an FQHC in DC, and getting them to that postpartum visit is really a challenge, and they're dealing with a lot. They may not have a bus ticket to get in. They may not have support at home, and may not be in a place where they're ready to pack up the baby and bring them in. And so going back to the report again that was funded through California Healthcare Foundation, when we did our environmental scan, what we noticed that the best practices and innovators in this space for the Medicaid population, they really focused in on home visiting programs. Instead of expecting her to come in, why don't we go to her? And investing in that step, looking at the role of community health workers, looking at the role of the doula if they started prenatally, and establish that rapport and that relationship, and having that set of eyes in the home to see what really is happening, and listening and connecting to resources and support. We also know from the report that moms are more likely to go to the first pediatric visit, but not necessarily their postpartum visit in the Medicaid population. So the pediatrician becomes a really important set of eyes and ability to do an initial screening, and making sure that we have the funding and reimbursement to support that, and that the pediatrician has the capacity to share that information to other providers as a follow-up for moms. So there are opportunities, but reducing those barriers in Medicaid is important. And you mentioned extending Medicaid and making sure that women have access and coverage through that first year postpartum. We know that over 50% of maternal mortality occurs in that postpartum period, and let a lot of women in the U.S. lose coverage in Medicaid after 6 weeks. So one of the quotes in the report that Pooja and I actually worked on, it's quoting someone else, but what would it look like for women not only to survive but thrive? And are we giving women enough chance, especially those in Medicaid, if we kick them off after 6 weeks? Especially if she has a newly diagnosed maternal depression or anxiety. And then we say, okay, good luck, and then we leave her. So looking at that and thinking about what that looks like for the program.
Thank you. So I have another layer to this, and I again want to turn to Jennifer, you, and Pooja on this, but just to dig a little bit deeper, what are some of the either institutional or cultural challenges that you see to delivering patient-centered and culturally aware 4th trimester care, and maybe some ideas around potential solutions to tackling these barriers?
Yeah, I think Jennifer hit on a couple of them already. I think home visiting programs are really important for that reason, because they really allow the they allow us to meet the woman where she's at instead of having to push her to come into a system that she may not feel well supported in. I think other things that are really important, one that works really well is group visits, so group prenatal care and also group pediatric care. So I used to work at San Francisco General Hospital, which is part of UCSF, and we used to transition women from group prenatal care directly into group parenting care. And it would be the same group of women who had been together their entire prenatal care, and they would come in as parents into the group, and we would provide dyadic care, right? So we would see them both at the same time. They could bring their other children, to your point, to the groups, even though that wasn't truly, along with the model. We would just give them something to do and feed them, and that really allowed for women who were at the same point in their lives in terms of around the same age babies to connect in a really different way and be able to support each other in a really different way and spend a lot more time with their providers. So I think group prenatal care and group parenting care is really important, or group dyadic care. Those are a couple of the things for me that come to mind, and I think there's better things that we can do as a system to support all of those things. So we really need to think about how could we bundle an entire episode of care so that we are thinking about providing, what does it look like to provide care for the entire first year of life for mother and baby, and how could that be paid for in one episode of care, just like we pay for pregnancy as an episode of care, right? And so I think we need to really start thinking a little bit more broadly about what does an episode of care look like for a mom and for a baby pair.
Thank you, and I wonder if either one of you can jump in as well, because I think one of the things that we've heard in our work, and I'm sure you hear in yours, is providers' ability to understand what their patient is going through, and for the patient to see, wanting to see themselves reflected in their provider, either on the level of race or ethnicity, language, and hopefully that provider is somebody who's specifically from their community, ideally. But how do you think about what are some of the strategies you think to give providers tools to, if there is a mismatch in that provider and that patient, trying to, again, give that culturally aware or at least conscientious care? So,
yeah, returning back to the report again, I mean, it's perfect. Again, looking at best practices and innovative approaches. When I think about back to when I was training to be a clinician, the term culturally competent care was being used. And essentially it encompassed knowing what types of food someone would prefer based on their race, ethnicity, religion. And that was it. And we've definitely evolved, but think about the cohorts of clinicians out there who have never been trained in this space, truly trained to understand, respect, listen to cultural differences. But again, the report, one of the things that we thought was really interesting, that a lot of community organizations and also health plans noted that really helped to transform their ability to connect with their Medicaid members and also address issues that may not have been explicit, but they understood, was by making sure that everyone within their organization was trained. That means the person who answers your phone goes through the same training as the clinician or the care coordinator or whomever, and it has to be embedded into your own organization before you can expect it to be brought out into the world and shared with others. And I thought that was a really striking point and something to share and to consider. I know that for large corporations like IBM, this is like, yeah, we do this all the time, or Cigna, but there's medium and smaller size organizations that may not have thought of this, and integrating that is really critical.
Jennifer, I would also add, we really have to pay attention to the pipeline, right? Recruiting more people of color into the profession, it matters, and that's something that's much broader than this discussion, so I'll just leave it at that. And then I think that there's other ways of thinking about co-located care that really pull in the community in partnership with the medical setting. And so the JJ way is one that comes to mind, and that's something maybe you guys could look at later, but there's this woman named Jenny Joseph who's doing this incredible work in Florida where she's bringing together the clinicians and members of the community into the same space to take care of that family, and providing this sort of wraparound prenatal care that really hits all of those points in making somebody feel like they're in a space where they're understood and respected and receiving good care.
And two other examples, but I'm going to let him pass on, but like Mama Toto Village in DC is transforming care in DC and thinking about it from a cultural perspective. And then Birth Detroit, this is a community rising. They're creating a birth center, and the community is defining what that looks like and how it reaches their community. So I highly recommend checking out both of those two.
You know, I think it's fair to say there probably are more female than male doulas out there. And when it comes to mental health as well, many women would probably prefer, if they could, to see a female provider. And one of the things that we're quite careful about, or that we monitor, is our balance of male to female providers. And I can tell you, in 2019, almost 80% of our master's level clinicians are women. For psychologists, it's just a little bit shy of 70%. And for psychiatrists, whether MD or DO, the number has been steadily increasing from about 37% in 2015 to 40% in 2018 to 43%, so we're moving in the right direction, in 2019. And so, again, something that we hope will help people to feel comfortable when they are able to connect with a clinician.
Thank you very much. That's certainly something that you think about from a consumer perspective, and it's great to hear how Cigna and other organizations are trying to meet the needs. So Pooja, I want to ask, I know you touched on a little bit about some of the kind of provider-centric strategies, but I want to ask, as a payer, what are the things that that you've seen and that you're doing at HealthNet to promote equity?
Yeah, so HealthNet has put a really big focus on equity in maternity care in the last few years, actually. And so just to give a little bit of background in terms of some statistics, in Los Angeles, the most recent data shows that African American women have a 4 times higher mortality rate than any other race. And they have, African American infants have a 3 times higher mortality rate than any other race in LA County. So it's quite striking, those numbers. And so we've put a lot of resources towards really addressing that huge disparity. So we have 2 active projects going on right now. One is our HealthNet doula program. It's in flux right now in terms of what it's called, but we're still calling it that for now. This is a program in which we are providing around 100 African American mothers who are on Medicaid in the Los Angeles area with African American doulas from within their own community through a community-based organization. And they're community-based doulas, which means that they have additional training in the social determinants of health and how that affects maternal outcomes. And they are going to be providing prenatal visits. They'll be there for the birth and for a few hours postpartum, and then they'll also provide 3 postpartum visits. And we're pretty early in our pilot. It's a about 1 to 2 year pilot, depending on how long it takes to get all the patients in, but we have really amazing outcomes already. We've had 18 births, and 17 of them have been vaginal births. In an area where 50% of African American births are usually cesarean sections. So our initial outcomes are really promising, and we're really excited to see sort of what comes out of it at the end. Another major initiative that we're funding is an initiative called Communities Lifting Communities. And this is an overall initiative that's looking at improving and having healthier births and safer births for all Black and all other families in Los Angeles County. And so this is an intervention that occurs at 3 different levels. One is the clinical level, one is the community level, and then one is the institutional level. And so we're doing work in a lot of different areas, partnering with the iDream organization with Coach V in the back and the Hospital Association of Southern California to do implicit bias training in some of the hospitals, to have some interventions within the hospitals where actually some of the hospitals are at the tables with us and sitting down and having conversations about why there's a huge disparity and what they can do about it at each institution. And then we're also going out into the community and having folks from the community weigh in on what would help improve those things and take action together.
Thank you very much. That's really exciting. And so I want to make sure we give enough time for folks in the audience to ask questions and share your reactions. But before we get to that, I do want to ask a happy question to kind of close this out a little bit, which is, if you had a magic wand, you could change anything about the system in terms of payment, care delivery, policy, or consumer engagement. And some of you have already mentioned a couple of these strategies. What would it be? And we can go in any order.
I think I kind of covered. Mine would be the levers, just to get people that need care, care. When I go out and meet with employers, so part of my job is vendor management. So we go out and make sure they have the right partners, make sure they're getting everything out of that relationship that they should be getting, go out to bid if we need to. But for me, if you really want to impact the health of your employees, vendors matter a little tiny bit, but it's the culture at the workplace. So for me, being able to go out and address stigma, increase awareness, make sure your managers know how to recognize, respond, and refer people who are in distress. It really starts at the culture at the workplace and probably outside of the workplace as well. So I would want to see more focus on culture.
I'd be remiss not to say innovate as part of our name and Institute for Medicaid Innovation, but I would say innovate and partner and don't give up. So the initiative that we're working on right now, where it's a learning collaborative and team between the state Medicaid agency, the health plans, and the provider groups, is probably the hardest project that we have undertaken at the Institute for Medicaid Innovation. It is not easy to transform payment, and it's not easy to transform payment in maternal depression and anxiety in Medicaid, but we're doing it and we're not giving up. And I would say for everyone, just continue to innovate, continue to partner, and don't give up.
And for me, I would say improving access to care for moms at a reasonable rate for them and eliminate as much of the friction in the system as possible so that they can get the help that they need for the lowest cost possible.
Yeah, I mean, I would say I would piggyback on both of those and say I think the biggest issue is really siloed care. And we're all in this room and we can agree on what we'd like to see. And so really pushing for that cross-sector collaboration so that we can break down some of the silos and really use all the work that we're doing to do what we all really want to do anyway.
Yeah, unfortunately, Carole took my magic wand and she said access, which is what I would have said too. And we actually are working hard on that. This quarter, we rolled out a faster access program, which for people participating in that program, providers participating, it means a callback to a patient within a day, a therapy appointment within 5 days, and an appointment with a psychiatrist or prescriber if needed within 15 days. And this is in 24 markets, or will be by the end of Q1, including LA, where there's certainly a strong appreciation for psychotherapy and the like, and then nationally later this year. So I'm absolutely with you on access. critical issue.
Are you reimbursing different in that express network to get providers to respond that way?
Yeah, we are certainly willing to where we've needed to, although what actually makes it worthwhile for the providers is knowing that there will be a significant influx of reliable patients who are going to come in. So, these are typically not mom and pop shops. It's larger clinics where volume is, where they're better able to accommodate volume and perhaps looking for volume. But we can certainly reimburse as we need to, as I mentioned on an earlier panel.
And just a follow-up on that, is that, growing the volume, is it within a lot of risk-based environments and contracts already, or just generally is the carrot to providers growing that volume and having that consistency?
My understanding is it's agnostic of where the risk is actually. Yeah,
Oh,
but
great.
just increasing the access across the board.
That's great.
Yeah.
Carole?
Can you comment, Stuart, on consistency and what you mean by that, what they're looking for?
The funny thing about the way a lot of clinics run is if you call them up and ask for an available appointment, what they'll tell you is they're full, right? Or they'll tell you we don't have an opening for 4 weeks or 5 weeks. But if you actually look at who is coming in the door, they're not full. And part of the reason for that is there are a lot of no-shows, right? And particularly in a Medicaid type of clinic, right? Where the rates can be up to 50%.
50% is the average.
50% is at the average, yeah. So a little bit less so in the world that I work in, but still fairly significant. And so the challenge, and so the consistency is important, ensuring that people do walk in the door. And where the clinics have to do some work is to figure out, well, how do they handle no-shows? Do they have a reminder system in place? Most clinics do. Do they have a system for outreaching people on a wait list? Some do, some don't. But you can actually get a lot more people into a clinic than might first meet the eye if you can handle the significant vacancy rate, as it were. So that's what I was referring to. Yeah, thanks, Carole.
Well, thank you, everybody, for sharing what's happening within your organizations. And now I would like to open it up to the room to find out what are the questions that you have.
Hi, I have a question around, let's see if I can try to wrap it into a small question. So I have a pretty eclectic experience. I was an insurance broker, and then I went into the nonprofit world, and now I'm a administrator/clinician, so I'm kind of a unicorn. I grew up in MHSA funding, so I have a really different perspective. But as you guys are talking, and we're talking about people not showing up for appointments, we're talking about the billing not being effective, I'm just wondering about what are people talking about how we're going to engage people? Because if we're talking about a taxed workforce and our providers are really exhausted, and we're talking about people not showing up to appointments, then there's something that needs to shift with inside of that.
I agree we have to do something. One of the things I wanted to mention that is top of mind for employers is the changing demographic in the workforce, right? More than half the population today, the work population, are millennials and Gen Zs. Their incidence of depression, anxiety, even suicidal ideation is off the charts. And they access care a little bit differently than generations in the past. So we've got a lot of innovators out there. They're looking at different apps. I was talking about one earlier that I met with yesterday where the first session is telephonic with a clinician, and then it's more digital based after that. You get assigned mindfulness and CBT. The therapist will text you throughout the day just saying, hey, how's your day going? So we see a lot of people looking at alternative ways to deliver care. We know for this, again, population that's about to really take over the workforce, we're going to have to do something different because, one, they consume differently, and two, because they seem to have a greater incidence of mental health.
And Rick, I know you mentioned earlier too that it really, part of it is the structures, but a lot of it also is the culture at the organization matters a lot. And so I wonder if you or Carole or anyone else actually on the panel can comment a little bit about, not just the family leave and paid family leave, those kind of policy things, but maybe things like flexible work schedules and because that to me, as a millennial, is really a culture piece, and honestly really drives my choice in where I want to work.
Yeah, that's consistent with what we're seeing with your generation and the Gen Zs as well, and that financial incentives aren't the thing that motivate them the same way that time off. The numbers on the millennials that are willing to take a job tomorrow, a different job, if they have that opportunity, is higher than we've ever seen before as well. So if you create a culture of caring where people feel supported, they have leaders that are empathic, and you just connect them. Stuart was talking about loneliness earlier. We chatted last week. I'm on my third attempt to write my dissertation, which is on loneliness and social connection. But when you look at loneliness in the workplace and you see the impact that it has on people's health, but also productivity, and the Gen Zs and the millennials are the loneliest of all, and now they're going out into a workplace where they don't have the skills to connect with people that impacts collaboration. If we don't start changing the culture, getting people to feel included, feel connected to the tribe, we're going to have a lot more problems than we have today. So that's why I try and focus on culture whenever I can.
And I would just like to go back to her original question. And one of the things that we do at the Institute before we start any project is we bring together people who essentially are going to be impacted by whatever the initiative that's intended to impact, and we ask them what they want. And so often we assume that we know, and then we develop something and we implement it, and then we ask, well, why didn't it work? And when we talk about care that's a cultural care that reduces stigma and bias and racism, like talking and hearing that story and that narrative and understanding what that means is really, really important. The number of times that a vendor will come to the Institute and tell us how great their product is and how they want to partner with us on a project, which we've never done, and there are some great vendors out there. But when it comes to maternal health, I'm really sensitive to this. And I always ask them one question, and none of them have said yes. And I said, how have you engaged women who are enrolled in Medicaid to design your product? And all of them are like, well, we didn't think about that, or we didn't, or we read articles and this is how we created it. But they never engage their intended audience. So then I say to them, so how am I supposed to work with you? Like, we're focused on Medicaid and women for this project. You've missed the mark here. So engaging and asking those questions and not assuming that you know is really important.
Yeah, and on that topic too, I think there was an earlier comment on another panel about helping moms to get to those appointments, or anyone who's struggling to get to those appointments, and what are the barriers to having them get there. So childcare, transportation, I think those are things that'll help with, especially in not employer-sponsored populations. I wanted to comment too on something that you said, Rick, about employers and how we're addressing the whole maternity. IBM has done some work actually in India and in Brazil so far, and we're now piloting it in the US, where we look at the whole experience from pregnancy to childbirth to return to work, and how do we make that as smooth as possible for the mom. And honestly, in an economy where we're struggling to find talent, it's incumbent upon employers to be doing this kind of thing, because it's the only way we're going to get moms back to the workforce. And of course, we want strong, healthy moms to come back to the workforce. And to your point about talking to people who are really accessing the system, we use a system very similar to what Melissa was talking about with her program. It enterprise design thinking, or agile, where we will bring a group of users into a room and talk about what are the pain points, what's working, what's not working. If you could design this any way you wanted to, how would you do it? And I think these kinds of forums help to do that, bringing stakeholders together, but there might even be something more formal where we talk about, okay, what are all the problems and how are we going to fix it together?
You know, I'll just say, before I was a child psychiatrist, I was a psychiatrist. And before I was a psychiatrist, I was a medical student. And in medical school, you take a lot of multiple choice tests. And your question was a complex one. I was wishing you could have phrased it as a multiple choice for me. But barring that, I'll say that there are a lot of barriers that we've been talking about. One of the things that we have is what we call the community support program, that was initially something we just did for people who bought insurance products on the exchanges, and we're probably in lower SES groups. We now offer that across our book of business, as we say, but it's exactly, you know, these kinds of things, figuring out, okay, someone needs help with bus fare to get to their appointment, or they actually need someone to babysit their kid, or sit with their elder parent so they can get to an appointment. How do we ensure that these basic kinds of needs that may seem unrelated to healthcare but intimately are ultimately get met so that they can have access to the care they need?
Thank you very much for that multi-layered question. That was a very helpful.
My name is Nakia, and just to put it out there, I'm a registered play therapist, and I hold a PPS in school counseling. So most of my career, I've been working with children. And as I've worked with children, I found that I need to work with the mothers, because as you mentioned, moms are the ones who tend to make decisions about care. And because I'm a woman of color, I tend to have a long wait list of other families of color, because they're really desperate for a familiar face, particularly one who specializes in play therapy and kind of like alternative interventions, because there's a lack of trust. The reason why I'm putting this out there is because I'm paneled already with most insurances. I'm on Cigna, HealthNet, Medicaid, Medicaid. We accept it all. We're a group practice.
Thank
we have
you.
a very diverse practice, and we have partnerships with domestic violence centers, with all these people out there who are working with children and families, because that's what I built my business on. Now, all that being said, we have no problem getting clients. We have no problem getting them into the door. My issue is I wasn't aware of any of these programs that are existent. And I just recently, in November, went and got my community-based doula certification, and have actually incentivized my other therapists to go get that, because I see that's where we're going. So I'm trying to help our community already have access. But I need to know from you guys, how do I know about these programs? I know we get these middle of the night faxes about things. I don't know if other providers get those.
The rates are cheap. The rates are cheaper in the middle of the night.
Oh, is that what's happening? I don't know, but sometimes as a director of my program, finding these faxes that I got at 2 a.m. in the morning is not our priority. So can I ask you, where am I going to get access to all of this wonderful stuff, like helping my clients get transportation to our center, helping them get childcare? Because right now we do provide childcare, but we charge them childcare while they're coming into services. I would love, like, hey, did you know Cigna does this? Did you know HealthNet does this? So please speak to that for me. Thank you.
Yeah, that's a great takeaway for me, actually, because you know, all of these are what we would say customer-facing, but we want to let providers know as well. So let me chat with the provider folks at our table. Actually, we have one or two there, and find out what we have specific. I mean, the cheap and easy answer is give us a call and we'll tell you, but how would you even know to call? And that doesn't really help. So, yeah, right. So let me see what we have specifically available for providers. We do have provider newsletters, but I don't know actually when the last time is that we specifically talked about the community support program. Yeah, specifically for maternal health. So that is I used to know the folks who wrote those newsletters. Let me do a little bit of digging around, and thank you for that. That's a great takeaway.
I agree. I think that's a great question. We do have community-facing people. So we have two different sets of medical directors, and we do have medical directors that work directly with the people that we contract with in the community. And so those people are always available to you, and they have one per area, geographic area. So I think for Los Angeles, that would be one of two people, so I could also connect you to them, and they would be able to give you all of the information about what's available. And then we also have community-facing people who do that as well. So we do have, in Los Angeles, we have Kristen Schlater, who's actually out in the community all the time talking to people and representing HealthNet and bringing things back and forth. So I think finding how to connect with those people, I don't know how, but I can get that information for you. It's different because what you're looking for is local, right? And the local people are out in the community all the time, and you should be able to access them. And it may be that the docs are interacting more with the larger practices and not the smaller practices. That's probably part of it, but certainly Kristen is out on the ground talking to people all the time.
Thank you. So I think we're right up at this.
One quick comment,
perfect.
if you don't mind.
Thank you, Joy.
I just wanted to comment on the employee assistance program that we've had conversations about, and Carole knows where I'm going to go with the statement. I struggle with employee assistance programs to provide mental health services. I think every company and every employee should have access to employee assistance for things like finding discounted childcare and those kinds of services. I think if we're paying premiums, society is paying premiums, we're paying premiums, our employers are paying healthcare premiums, that benefit should be available and accessible in network through our benefit plan. So I am not a big fan of EAP programs for this reason. I feel like it's a Band-Aid that's instead of investing in the broken system that we're Band-Aiding. It's a Band-Aid approach. So just wanted to make that comment. And
how would you approach solving that if it wasn't through an EAP?
Addressing what we addressed earlier today around ensuring network adequacy exists for mental health.
I love Joy, but I have to give a counterpoint to that. And I'm Laura Clapper, I work at Cigna, but I've worked at HealthNet and I've worked with Carole on the national account side. So I've seen EAP work really well for mental health services, and I was actually going to make a comment that providers need to use EAP more. It's kind of a hidden benefit. So if you're a provider seeing someone who needs mental health, and this doesn't help people who are uninsured or on Medicaid or something like that, but if for the 50% of moms who do have employer insurance, they have EAP. EAP has counselors that are available by phone right then, 24/7. So you could literally walk someone to the room next door, have them call the number and talk to a mental health counselor. That's how EAP works. And well, I mean, that's another conversation we can have. But what I like about EAP, there's no co-payment, no co-share. So in the life of high deductibles and things that have been put in place around employer insurance, and people worry about getting care, and we know from the data are delaying care because of high deductibles plans, they can get mental health today through their EAP. I just think it's a benefit, and for your household, right? So your mother-in-law who lives with you, who's 60 and doesn't have health insurance but is crying in her room, can use your EAP benefit. It's a benefit that is available where that's underutilized, and I just think we all need to think about it's there, and people aren't using it even though we're crying out for this kind of need. So
Joy, is what I'm hearing you say that EAP is a Band-Aid because it's not true mental health care? Because it's the same clinicians, but...
I mean the healthcare premiums and the benefits should be available.
So, yeah, as far as counseling, yeah.
You shouldn't have to go to an EAP program. The benefits are purchasing should work fast.
Okay, so we heard about mental health parity a little earlier today. One of the things I do is go out and do parity audits on health plans. What the law says is that mental health can't be any more stringent than medical, but it doesn't mean it can't go the other way. So health plans or customers can ask for zero deductible, no copay for mental health services within the benefit. I think it'll end up looking very much like the EAP because they're similar provider networks, but if an employer really is struggling with that, you can just take away the cost that you have to pay. You can't do it the other way. And it's something I would love to see happen too, because it's a barrier.
And I think employers are doing that.
The only, I think, a barrier to that is an employer who has a plan that's HSA compliant. So if you know about health savings accounts, the IRS gets involved and says that only certain things can be covered at 100% before you've met the deductible. We've made great strides on that list of things that can be covered. The list just expanded last year. Unfortunately, mental health is not one of them.
It's changed.
Yeah.
Well, thank you, everyone. This was a really robust conversation, and thank you to all of you for hanging in there a little bit after 5. Do we want to maybe one very last time? We can
Do more. Good.
Thank you.
Blair.
Thank you, Joy, and thank you for everyone on this panel.
Thank you, Carole. That was great.